Thank you for joining us in this session entitled Main Squeeze Gone Wrong: The Downstream Impact of Venous Thromboembolism and the Lack of Use of Intermittent Compression Devices. My name is Charissa Cordon. I will be the moderator for today's session, and I will be joined by my colleague, Dr. Parth Rali. So a little bit about myself. I have a 20-year experience as a nurse, and I currently work as a senior nurse leader with experience in leading large transformational change initiatives in complex organizations. I have led initiatives at the provincial and national level, and as a leader, I have championed many patient safety initiatives, including standardization of practices, policy, and protocol development, program evaluation leading to improved patient outcomes. I have also led an interprofessional team to standardize the practice and approaches to preventing venous thromboembolism. So now let me introduce Dr. Parth Rali. He is an associate professor in Division of Thoracic Medicine and Surgery at Lewis Katz School of Medicine at Temple University Hospital in Philadelphia. Dr. Rali is the director of System-Wide Pulmonary Embolism Response Team, also known as the PERT program, and the Anticoagulation Stewardship Committee. Nationally, he serves as chair of National PERT Consortium Protocol Committee. Dr. Rali is also a member at large for the American College of Chest Physician, Pulmonary Vascular Disease, and Cardiovascular Network. He recently got appointed to the role of Senior Advisor for Global Thrombosis Forum and Vice Chair of ATS Pulmonary Circulation Early Career Group. He is one of the guideline author for Chest COVID-19 VTE guideline. So you'll see that Dr. Rali has a lot of expertise in venous thromboembolism, and he's quite published in this domain with more than 40 clinical trials in the last 5 years at Temple Lung Center. So let's get started. So my first question, Dr. Rali, can you please tell us, why is it important to talk about venous thromboembolism?
Thank you, Charissa, for a very nice introduction. So it's absolutely my pleasure talking about this disease state, which is very close to my heart, as you correctly mentioned earlier. So on a global state, I think one thing that we need to understand that when we talk about venous thromboembolism, we have to keep in mind that we are talking about the spectrum of disease, which is deep venous thrombosis, which is a clots in the leg, and a pulmonary embolism, which most of the time the DVT in the leg breaks off, and we know that it gives you a pulmonary embolism. Sometimes we'll have the healthcare workers and the patients not connecting two dots, that it is part of the same spectrum, whether patients have DVT or PE. It ultimately leads to same adverse outcomes. And I think so is that I'm very curious to even understand, I think, is the way you do the prevention at a global or at a larger scale than what I do in my practice. But I think going back to your question, I think understanding the VTE burden is important. Globally in the United States only, that we know that there are 900,000 VTE cases every year. And this report by far we know that does represent the tip of the iceberg, because there is not a good system to track those devices, and that these data are not updated very often. And out of 900,000 VTEs, there are 100,000 deaths related to venous thromboembolism. And I think this is something significant. So if you are a VT fanatic like me and take those numbers and divide the mortality rate every 6 minutes in United States, there is somebody who is dying with venous thromboembolism. These numbers are staggering. If you combine the risk stratification models and the global prevalence model, and if combine Europe and United States, that number may come down to as 1 every 3 minutes of VTE related death happening. And this is unbelievable. Also, we need to know that everybody talks about the stroke and everybody talks about MI. I'm talking about more of a patient perspective level, awareness level. hardly 1 in 10 patients have even heard about a blood clot and a disease that can affect anyone. So I think we had to take in mind that there is lack of awareness amongst the patients, and also the VTE affects all the different kind of patient spectrum. That makes it more interesting, but at the same time more challenging, because you could have a patient who could have a bronchitis and they have a VTE as the ideal diagnosis. Same way you could have patients who is postpartum and pregnancy and they're just short of breath, and they could have VTE as a diagnosis, and that could be life changing. So I think one of the biggest challenges for the healthcare providers that it's not a one particular disease state that gets assigned to one particular specialty. Like if you have a stroke, you always have a neurologist. If you have an MI, you have always have a cardiologist. Versus VTE can affect anyone from a primary care physician level all the way to the people who work in surgical side or in the medical ICU side like me. We all get to see the different spectrum of VTE.
The data you have provided us is quite compelling. Dr. Rali, your experience heading up the pulmonary embolism response team at your facility means you encounter patients when they have experienced an acute pulmonary embolism. Can we talk about the impact of VTE? Why does this matter? And in other words, how does this impact the patient's quality of life? And what is the impact on the healthcare system?
No, I think that's an excellent question, leading to our next phases of discussion. I think my experience at starting a temple, we are a network of 4 or 5 hospitals, and we have a system-wide PE response team program. And I think I'll try to break down the questions to your answers, and I think we may have to come back to some of those questions. But what I want to say that PERT is the true representation of standardizing the PE care. So what I also would like to take away for our audience that it does not mean that you need to have certain characteristics of your PERT team. I think when we started the PERT team, and I think now where we are, I think we have learned that each PE response team at every single institution will have to have the local champions. I think if I had to summarize what does the PERT mean to me, and I think what does the PERT mean to me is that identifying your local champions, identifying your local resources, and using both of those combined with the help of hospital administration to put into the fact the care that you would want the best for your patients that you serve. And I think when you do that, that's what the PERT truly believes in, that you get like-minded individuals who care nothing but the patient care and put that process into play. And that's what the PERT stands out for us. We have taken care of more than 1,200 patients over the course of last 5 years with the pulmonary embolism. And I'll tell you that I do remember the patients who have adverse outcomes, because those are the patients that keep me awake at night. Those are the patients that I always look into to improve. Not everybody you can say, but every patient teaches you a lesson and helps you prevent a next death that will lose from this preventable disease state. What does it mean for the patient? I think what we like to say, for example, for PE response team, and why it's important, why its time sensitiveness comes into play, because what for stroke we say time is brain, for heart we say time is muscle, right, for the MI, and for the PE I would like to say time is breathing, because the patients are extremely short of breath. And I think, as we previously mentioned, that shortness of breath does not mean it's a blood clot, but if it is a blood clot, you do not want to miss it.
Based on your experience, for patients that have been diagnosed with a PE, let's say, can you describe what they typically look like 1 year post-diagnosis? Are they able to go back to their baseline? Are they able to resume quality of life? Or do they get worse in their illness trajectory? Can you just go over that a little bit more for us?
Yes, I think that's an excellent question. I think when we started the PERT, I think our whole focus, and I think everybody's whole focus was providing an inpatient care. And the moment we started the PERT and we started treating those patients, and some of the patients, because of the risk-benefit ratios, we decided to treat one versus other way. All of a sudden, we realized that these patients are going out in community, and who is following them, right? And I think that's what led to the whole concept of what we call as a post-PE clinic and a post-PE follow-up. I would say that who should do post-PE clinic and post-PE follow-up, I think should depend on the local resources. Example, like I cannot say that every place this person should be followed by a cardiologist or pulmonologist or hematologist, because if I do that, then I'm defeating the purpose of a post-PE follow-up care, right? I think what we realize that we need patient care, taking care of the patients when they're admitted. Then we need a transition of care. So those patients are discharged safely, they are made aware of their disease state, and the transition of care team bridges those patients to the proper outpatient dedicated follow-up, whether it's a cardiologist, hematologist, is in a multidisciplinary clinic, whatever it may be, but those patients should not be thrown out in the community. And I think even across the country, we know that it's a 30 to 40% of the patient gets lost to the follow-up. Even at our center, where we have a post-PE follow-up, because of the lack of education, awareness, and the issues that we have across the health systems, across everywhere, we lose 30% of the patients who were seen as an acute PE patient, inpatient, but they did not follow with us as an outpatient. But those who follow, I think your question was, how do we manage them and what do they look like, right? I think one of the things that I realized that PE is an opportunity to look into somebody's health. Because what we realized when I started seeing those patients in my clinic, all of those patients have multiple other risk factors that have not been explored, right? There is a group of patients who just gets a PE and they're healthy, but majority of the patients already have the coexisting cardiopulmonary diseases, which are either not diagnosed, either they are ignoring, or they're not even aware of. And to give an example, we actually end up diagnosing 10 to 15% of the patients who were just followed up PE, but we end up diagnosing a secondary cardiopulmonary diseases. What are those? Those are sleep apnea. 1 in 10 patient has a sleep apnea. When we kind of follow them and check for sleep apnea, they're positive for sleep apnea. They have COPD. We end up identifying lung cancers on those. You can understand the PE could be just a presentation, and there is an underlying cancer is always a possibility in 10% of the PE population. So you take that PE patient and you just treat the anticoagulation, you're missing out what could have led to a clot, right? So I think age-appropriate cancer screening. We also know that once somebody has a PE, that doesn't mean you're going to scan them head to toe, but taking an opportunity to do an age-appropriate cancer, a mammogram, your pap smears, your PSA for males, and looking for colon cancer screening. I think that allows us to look into their health. Also, at the same time, I think optimizing the chronic comorbid disease state is extremely important, because that's going to contribute to their level of recovery.
Great. Thank you for that. So what I learned with what you just said is that PE is a complex diagnosis, often presents with other comorbidities, not alone, which requires quite a bit then from the healthcare system. You also indicated that 1 out of 3 individuals diagnosed may not necessarily go back to the baseline, which I think is something new that I'm learning here, which in my mind makes prevention even that much more important. What advice do you have for physicians and the interprofessional care teams in preventing venous thromboembolism?
I think what we are addressing right now, what should be physicians and the nursing and the healthcare professional doing while patients are admitted, we are talking about a primary prevention. And I think there is a second part of the treatment is a secondary prevention, means that somebody who has a VTE, how do you prevent a secondary VTE event, because that could have a different life-altering duration of anticoagulation implications. But I think going back to your first question, I think one thing that I think what we need to remember, this is the preventable disease. And I think so far in our discussion, we have focused on therapeutics and outcomes, but also I think sometimes we forget and we take things for granted. And I think this is unacceptable. I think, as you can see, that a lot of times we'll talk about therapeutics and advances in therapeutics, but I think the primary focus is on prevention, because this is one of the preventable cause of death. And I think this is kind of how It is different from stroke and MI and all other leading causes of inpatient mortality, that VTE is always referred as a preventable cause of death. That means we can prevent it. How do we prevent it is some of the things that you asked, whether which patients are at the high risk, right? I think we know that in the hospital system, everybody gets put on universal prophylaxis. But when you kind of scratch the surface and you see that how many patients are getting a universal prophylaxis, 15% across the nation is a VTE prophylaxis is not given or interrupted for a variety of reasons. Some of the reasons are that patient is getting different procedures. Some of the reasons are that patients are refusing. Some of the reasons are related to the timing of admission, because you admit a patient and you put in the order and then everybody takes it for granted. Nobody offers them alternate options. Some of them could be an oral drug. Some of them could be mechanical prophylaxis. I think those things do not happen in our healthcare system, because I think as you said, people just are the healthcare providers, nurses, physician. We only look them at one point of only one step in time. And downstream effect is that the VTE risk is not only in the hospital, but the first 30 days post-acute discharge, you have a high risk of VTE. So there's a good amount of data that when somebody tries to make the patient aware, make the staff aware, the rate of refusal goes down. Meaning that how many times I have seen, and probably not that common, when somebody refuses subcutaneous prophylaxis, that gets documented in medical records. But what if you go to that patient and say, hey, there is an oral option there, or there is a mechanical option there? And I think all of a sudden the patient's refusal rate will go down. And we have shown that data. I think creating a dashboards for our physicians that, okay, out of 10 patients that you're taking care of, 3 of them have refused the VT prophylaxis of any sort. I think those kind of data are extremely helpful. So I think in that era of informatics, I think our electron medical record systems are getting smarter. And as you kind of mentioned during my bio introduction, I think one of the anticoagulation stewardship committee, that's some of the things that are very close to me, right? I think one thing that I realized that yes, being a director of PE response team program is great because you can treat the patient. But I think by doing that, I realized the importance of the prevention. And I think that's one of the big things that we are trying to address as a part of our anticoagulation stewardship committee, that it's not only the treatment, but it's also the best prevention practices. And I think that goes the answer, that it's multifaceted. You could have a surgical patient who cannot receive the medical prophylaxis, then they should be offered mechanical prophylaxis. But mechanical prophylaxis, how many times you order a mechanical prophylaxis and those mechanical prophylaxis not even on the patients, they're somewhere in the room but not on the patient. I think so ordering is one part, but I think execution, identifying the problems and troubleshooting them so that actually patient do get that care. And more than anything, education, because think about it, it's not convenient to get shot with in your belly every day. It's not fun to have something wrapped around your legs every day. But I think those are the things that I think as a physician, as a healthcare professional, as a nurses, I think we should take pride in preventing this preventable disease state and eventually our adverse outcomes. So now all of a sudden you're increasing the work, and I'm very mindful. I think whenever I try to implement a change, being on the other side, being a chair of anticoagulation stewardship committee, I had to put myself in the shoes where I'm taking care of multiple things at the same time. If I make anybody's life more complicated, it's an automatic set for failure, right? So example, I think what we did is that if somebody patient is in the ICU and you try to order an oral prophylaxis, which should not be the case, system will prevent you from do that, right? So it's in a system work. We do not want physicians who are working in ICU to stress about those things. I think we want to kind of focus should be creating a safety, but at the same time making the pathway efficient. And I think each prophylaxis or each subcategory of the question that you asked me, whether mechanical, pharmacological, or the subcutaneous, I think we need to think it that way. An example, one of the example that I just said, that what we are trying to launch is that we're going to create a physician columns, right? Of saying in the patient list, it's gonna say that if somebody misses 1 dose of prophylaxis, it will be green. If they miss 2 doses, it will be yellow. One patient misses 3 doses, it's red. So not only it's helping them having a list there, but it's also gonna visually impact saying, hey, somebody missed 3 doses, it's red. I do work clinically also, so I know how it's to be on the user end. But I think anything that we do, I think we have to identify how do I make it life easier. So with this, I think the rate of refusal of prophylaxis will go down. And it's not easy, right? If our goal is to improve the outcome of the patient, and everything else doesn't matter.
The PERT clinic you established at Temple University is quite impressive. I suspect you had to develop a very strong business case to get this started. Can you please tell us what advice you would give physicians on how to effectively influence hospital administrators to invest in a VTE prevention program that may be more costly at the outset, yet will enhance the patient path of care and outcomes and after they have gone home?
So I think, Charissa, this is the toughest question that you asked me, right? I mean, I think I can talk about PE and VTE all day long, but you asked me a business question now. No, but I think your question is well valued. So I think one thing that I did mention previously, and I think that's what we should focus on, right? It's very hard for a physician or a healthcare professional or a nurse who has been trained like-minded to take care of the patient, and all of a sudden you have to go to somebody and ask them that I want to start a program, and you only thing that you can talk about is patient care, not the business side of the things. But I think that is also your strength, not the weakness, right? I think your strength is patient first approach, right? Your strength is that you need to make a case of what you firmly believe in, which is improving the patient centered outcome. None of the health system would exist if we do not say the patient centered outcome. One thing that I realized that I think also I mentioned is that you take every single available resource in the hospital, right? If you go to your administrator and said, hey, I want to have X amount of money to start a program or a year, and they will go through the different evaluations and cost value benefit analysis and all that. But I think you need to be cognizant that your step one is to establish a program at Temple. Our step two was to establish the program for a health system. Step three, how a program is going to differentiate from the program that may exist in the region, right? You need some of the things that you want to say that what are the centers in your region who offer the similar program. If they offer the similar program, how do you differentiate them? I think at some point you should have some point of mind how you're going to track your outcomes, right? And again, tracking an outcome is a simple thing that every healthcare C-suite will do that, right? You just need to create your models, right? I think the biggest part that I spent last year is understanding how do I track a PE patient, because it's not easy. It's not like an ICD code that you can say intermediate is PE and would look at the outcome. But once you do that, all of a sudden you can compare your outcomes to the outcomes which is happening locally, regionally, even nationally. And once you start showing the positive changes in that, that's when you can capitalize and ask for more resources. So I think that's where we are. I'm not done yet. I think I just did all of the things that I said. I think there's always a room to expand. And I think every clinician should back up their clinical skills and patient first approach, and the rest of the puzzles will fall into the place.
I loved, as a senior nurse leader, I appreciated your systematic and phased approach to the change management. What I heard you say was that you first and foremost started with how can we optimize our resources and do things differently. The second thing that you then said is you engaged others. Who can help me make this happen? And who can help me solve the problems, and what are the results we're trying to look at and achieve by doing things differently. The other piece that I heard you say was that you started small, you had your results and outcomes, and then you started to scale bigger. So you started in a small program, then you started to scale to other organizations. And then you thought about publishing the data once you started to see, that you're able to make changes at the patient experience and patient outcomes level, which I think is the right thing to do. And I would envision that you also had, in your case, well, what happens if we don't do this and if we did that instead? But I loved your systematic approach in transforming the system, but you started small and you started with an assumption that we can make something special happen. Well, Dr. Rali, thank you so much for sharing your expertise with us and for spending time with us. And so that concludes our interview on main squeeze gone wrong, the downstream impact of venous thromboembolism, and the lack of use of intermittent compression devices. Thank you.